Hello and welcome to the Neurocritical Care Society podcast. I'm your host, Nicholas Morris from the University of Maryland Shock Trauma Hospital. Today, as part of our Hot Topics series, I am thrilled to welcome Dr. Jose Suarez onto the podcast to talk about the recently published subarachnoid hemorrhage guidelines. Dr. Suarez, thanks so much for joining us on the podcast.
Thank you so much for having me. It's a pleasure.
And I can't believe there's anyone who listens to the podcast who doesn't know you either personally or by reputation. But can you tell them, for those who have been living under a rock, who you are and why we're here talking to you about the subarachnoid hemorrhage guidelines?
Yeah, sure. Yeah, my name is Jose Suarez, and I'm the chief of the Neurosciences Critical Care Division of the Johns Hopkins University School of Medicine, and I'm a professor of neurology, neurosurgery, and anesthesiology and critical care medicine here at Hopkins. I'm also past president of the Neurocritical Care Society, and as Dr. Morris already alluded to, yes, I participated in both the development of both guidelines and also in the prior consensus from NCS back in 2011.
Great. Well, thanks for actually mentioning that prior consensus. I think that's maybe a good place to start. Is back in 2011, the Neurocritical Care Society published this consensus statement, which isn't really a guideline. Can you talk a little bit about how that's different from the guideline that came out recently?
Yes, that is correct. So it was a consensus guideline. It was not, we did not have the methodology wasn't as worked out as it is now. And the idea was to convene a group of experts, and we did have a large group of people that met, and we sort of agreed on, after reviewing the literature, on which topics we would address. And at the time, it was meant to look at the critical care management of the patients. That was missing from the American Heart Association guidelines that were published back then in 2012. They did not address the critical care component that extensively. So we wanted to provide some guidance at the time and make sure that we had consensus among the experts as to what the topics were important and what to recommend at the time.
Great. And so that was back in 2011. And for this 2023 guideline that was published, I think, in May, there was some significant changes to the process or the methodology. Can you talk about this time, how the authors went about developing the guideline?
Yeah, this time was a completely different approach. And obviously we used the grade system, which is sort of become one of the recommended ways to evaluate the evidence of the literature for guidelines. So, and grade has evolved significantly over time. So initially it was a little bit challenging to sort of navigate the new grade system, but we were lucky that we also had experts in grade and experts in development of the guidelines. So this time, the way the Neurocritical Care Society organized it, there were 12 experts from a multidisciplinary group of individuals. We were all working in neurocritical care, and we were tasked initially with deciding which questions to address. And so we used the so-called the PICO approach, which is recommended by grade as well. And a grade usually recommends typically no more than 12 questions. So we agreed on 9 of them that we thought that were important to address. This was not meant to be a comprehensive review of the literature. We only picked the ones that we thought were important. And then 2 individuals were assigned to each of the questions. So we were assigned with reviewing the literature, looking at the evidence, and providing some recommendations for the rest of the group to vote on, and finally agreed on which recommendations to provide.
Great. I think that's such an important point in trying to understand these guidelines is it was really the development of the questions which then guided the literature search and the recommendations. And I think, as I interpreted it as a reader, these were really meant to help us, those of us in neurocritical care who are at the bedside doing critical care, and not necessarily to be an all-encompassing guideline from ED admission through surgical management. Is that right?
That is correct. And I think that's a very important point to stress. Now, the other thing that is important to remember is that at the time when we initiated the process, which was started back in 2019, that's when we started with the process, the grade system also felt very strongly, the developers of the guideline of the system, that we should stick to exclusively to the questions that we were asked to address. Grade has also evolved since that time. Now, grade also allows for some recommendation statements, that more leeway, if you will, for the reviewers to approach. And the way we handle that rigidity, we thought it was a little bit too rigid, is that we also agreed to write review articles with more clinical recommendations that would accompany the guidelines. And that's what you saw there with the guidelines, plus a set of articles with critical care questions that we thought were important.
Right. And I just want to direct the listeners to, I think there was a special, I think it was August when the subarachnoid hemorrhage individual articles came out. And I found those really, really interesting and useful, and provided some of the answers I think many people may have expected when they went to the guidelines, and they ran into this list of insufficient data.
Correct.
Yeah.
That is correct. This is why we thought that would bridge that gap, and that would be a way to do it, because obviously we take care of patients, right? So, and guidelines are guidelines, but they may not necessarily apply, to the patient that we have in front of us. And we thought it was important to address that with those summary papers that accompany the guidelines.
Great. Well, having that as a context, I think, is very helpful then for understanding some of the changes from that 2011 consensus statement. Can you summarize, for those who haven't thoroughly reviewed the guidelines, what are some of the big changes that readers can see when they compare the 2011 consensus statement versus the 2023 guidelines?
Yeah, so I think, as we mentioned, it was obviously more restricted with the PICO questions that we asked. Some of the recommendations, or one recommendation that was similar, was the nimodipine administration, of course, that's still recommended based on the evidence. That has not changed. But we did change the recommendations for blood pressure, for example, blood pressure management prior to aneurysm treatment. If you recall, back in 2011, we had this threshold of less than 160. So this time we by reviewing the evidence that we had based on the new grading system, we thought that we had insufficient evidence to recommend any particular threshold. So we decided to go with avoiding hypertension and avoiding hypotension. And I saw that probably for some people, it may sound like a cop-out answer, but it's really based on looking at the literature and applying the gradient methodology. That's what we came up with. So, but we also recommended further research, in the area, which is also important for people to realize. Now, we also recommended against, obviously hypervolemic therapy, and because we thought the adverse events outweighed the risks, outweighed the benefits, so that's also in the new guidelines. And also we had the newer evidence from the other randomized control trials that were not available back then, like, for example, the endothelin-1 antagonists. So we recommended against its use based on the current recommendations. Magnesium also recommended against. At the time when we had the 2011 guidelines, the magnesium trials were still, some of them were still ongoing, so we really didn't have any evidence. And the other important change was the recommendation against antifibrinolytic therapy. And that's also based on the newer evidence, the newer clinical trials that have shown that there is no impact on outcomes. So I think that we also recommended against that. So those were important changes, but I think it's also important for people to realize that this was also based on the review of the literature. And yes, it may sound like it was sort of a negative guideline saying that we didn't have insufficient data, or against it. But that's also important to know what not to give our patients if they do not impact outcomes.
That's great. I had the pleasure of hearing Mike Dieringer talk about the NCS subarachnoid hemorrhage guideline, and he made the astute point that for those who feel so enthusiastic about certain interventions that the working group found had insufficient data to recommend them, that in almost all the areas where there was a randomized controlled trial since the 2011 consensus statement, the trial showed no benefit to that intervention. And I was wondering maybe if taking a step back, if you could kind of pontificate, what is this telling us about this disease in our research and the frustrations that many of us have with either neutral or negative trials?
Yeah, this is a great point, Nick. And I think the one thing that we also stressed, and it may have gotten lost, in the because people are always fixated with only looking at the actual recommendations, that we also mentioned that there is significant variability, in the care of these patients, and even within the same institution, there is a lot of variance, right? But for example, we're deciding when to take someone for endovascular rescue therapy, for example. Let's pick that as a clear example. So there is so much variance between sites, between regions, and also within the same institution. So I think the point that we were making is that we definitely need to learn more about that variance of care and how that variance of care impacts upon outcome. We do have some preliminary evidence, when we did with for example, from the SAHIT repository, which is a repository of all the clinical trials that have been done. But that's all retrospective and in a review of the data. So it's limited because we don't know exactly what went into people's minds when they decided to pick one therapy versus the other. But clearly, the data shows that variance drives outcomes. So the more the variance, the worse the outcome of patients. So this is kind of interesting. So we stress that in the guidelines, and we think that may have also driven part of that of the negative outcomes. That's one point. The other point that we made, and we also made the same point for the AHA guidelines, is that we also said that maybe the way of the future is combination therapies. So maybe we should, take a pause, and think carefully. Are we going to continue developing a single therapies that address a specific pathway, or are we going to just combine therapies in addition to the calcium channel blockers that we currently give? And I think that was an important point. And the both guidelines came to the same conclusion, that maybe that's one way to also address this issue of negative trials. Maybe we just need to combine therapies.
Yeah, very interesting. I wanted to pick up on you said some of the limitations of the data available, where it's retrospective nature. I think in the NCS guideline, as a point to the sort of rigorous process that you all went through, you actually did a risk of bias assessment for all the literature. And when you look through that chart, it's incredible that most of the studies that were reviewed don't stand up very well. They have a very high risk of bias. What are some of the major risks of bias that you found, and how can we address these going forward?
Yes, and that's a very important point, and because it was also an eye-opening for us, right? Because we also, several of us assumed, that we were not going to find anything different by re-reviewing some of the older literature and presenting the new literature. But then once you put it through the test of the risk of bias assessment, then you realize that the quality wasn't that as great as you thought. And I think one of the major it was pretty consistent, particularly on the observational trials, but also in the randomized control trials, was the evidence of imprecision, right? Imprecision was an important point. They say that the confidence intervals were too wide. The sample size wasn't designed or wasn't calculated to address the hypothesis that they thought or maybe there was no hypothesis at all. So they just went to the observation. They wanted to collect the number of patients that they had at an individual site, or when they combined it with more than two sites, they tried to get as many patients with subarachnoid hemorrhage, but there was really not a sample size calculation or power calculation to address the hypothesis when there was one. But in precision, I think it was one of the main drivers of downgrading the evidence from good evidence to less good evidence, if you will. And that's why we gave the grading that we did for most of those.
Right. Now, given the relatively low incidence of subarachnoid hemorrhage compared to, let's say, acute ischemic stroke, the support for research in this area is relatively limited. And I think many of us feel like going forward, what we're going to rely on are clinical effectiveness studies in prospectively collected cohorts, but not necessarily, we may not ever get the funding to do all of the randomized controlled trials that we would like. You've personally been involved in showing that around the world we can collaborate and collect data in neuro ICUs. How do you see us moving forward where we can move away from these single center, small retrospective studies of certain interventions and can look really across multiple centers and perhaps even internationally?
Yes, you are correct. I mean that the number, of course, the number of patients with subarachnoid hemorrhage, especially aneurysmal, which is the population that we addressed specifically with the two guidelines. The number of patients like in the US, depending on which cohort you look at, is between 15,000 to 30,000 per year, right? So what that means is that by NIH definition, then it qualifies as an orphan disease, right? So less than 250,000 cases per year. So that by itself is a challenge, right? And I agree. So we need to reach out to our colleagues around the world to try to come up with a larger study. And, if you think about what the cardiology literature shows, they have 20,000 patients for a clinical trial, right? So, and we're talking about, 500 at most, for subarachnoid hemorrhage. And so, but the importance of reaching out to colleagues around the world is that we can also generalize the findings, right? Because they can apply to different populations. We can also exploit these variants that we talked about before and how that variance can help us answer the questions that we need, right? And I think that's so important. We also need to convince not only the funding agencies, like, for example, the National Institute of Health in the United States, because it's the major funder for clinical trials or studies, but also the reviewers, the scientific reviewers that sit on those panels. The subarachnoid hemorrhage is an important disease, right? And it's associated with the high mortality rates, and not only that, but also affects the younger population and a population that is at its peak productivity, and therefore is the one that is associated with the highest impact on society, because these are people that most of them are not going to be able to go back to work. Yet they're in their mid-50s, so they're still a young population, productive otherwise, but if you're nowhere for the subarachnoid hemorrhage. So I think it's important to drive that message. And I think obviously having this podcast is important because we're also sending out the message out there that we need to do research in this population. And we have to tackle it from different pathways. One, you mentioned, yes, absolutely. We need more well-conducted prospective observational studies. That's important. So we make sure that we collect them well and we do it prospectively and try to avoid as much biases as possible. But we also need to do the randomized control trial. I think the combination of the two will hopefully help us answer the questions that we need. Understanding that we may not have to answer every single question, but I think that we need to pick probably the ones that we think are the most relevant.
Great. Well, let's switch gears a little bit and talk about the American Heart Association guideline that was published almost simultaneously with the Neurocritical Care Society guideline. That one was in stroke. You were involved in the development of both of these guidelines. How was the focus different in that guideline compared to the Neurocritical Care Society guideline?
Yeah, the focus of the AHA guidelines was to provide a more comprehensive view of the disease from onset through pre-hospital care, hospital care, and then discharge and longer term. So that's one of the major differences between the two. And yes, we did address the hospital issues, including critical care issues, but it was a more comprehensive review, and that was the objective of the American Heart Association, and that's what the group was tasked with. But the other important point is the methodology. Methodology is different. Yes, it was also a multidisciplinary group of individuals that were convened, to answer the questions, but we were not limited by the number of PICO questions that we didn't have the grade. We just followed the American Heart Association guidelines recommendation, which essentially has two different types of recommendations, if you will. One is the the level of evidence, and the other one is the grading of the recommendation that we would give, the final that we'll give. Now, for the AHA, we also used a modified Delphi methodology, meaning two in the primary and secondary reviewers were assigned to most of the topics that we picked. And for the most part, we started with the topics from 2012, and then we updated them or agreed to update them, or some of them were agreed upon to continue with the same. But we also thought that there needed to be newer ones added to the list that were not included back in 2012. So then between the primary and the secondary reviewers, and some of those questions, because they were more complex, they may have had 2 primary and 2 secondary, but usually they have a primary and secondary, and then a tertiary reviewer assigned to it. And so those individuals were tasked with reviewing the literature, summarizing it, and then providing the preliminary recommendations. And then we presented it to the bigger group, and then we voted on them. And if the agreement was between 80% or more than 90%, it had to be at least 80% to be included in the final document.
Yeah, well, it's a very impressive document. It's a massive undertaking, and I guess I shouldn't have been surprised, but I was surprised to see, some people were even criticizing it for not being comprehensive enough, like not considering dissecting aneurysms or subarachnoid hemorrhage from an aneurysm associated with an AVM. But nonetheless, it's a giant body of work that you all summarized, and I think a really valuable contribution to the literature. Were there any big differences that you found between the 2 writing groups, the NCS and AHA writing group, in terms of the recommendations that you came up with?
Yeah, it is interesting that when you really look at the peak of questions that we picked for the Neurocritical Care Society, there's really no major disagreements. When you look at what the recommendations were from the American Heart Association guidelines, one thing to highlight, for example, probably would be the management of hyponatremia or fluid management. That the American Heart Association guideline thinks that it may be reasonable to use, fluorocortisone to decrease natriuresis. Now, but we also made the point, similar to the NCS guidelines, is that administration of that medication is not clear that it impacts upon outcome, right? But at least the natriuresis point, yes, it can improve, but the long-term outcome is not different. But the other questions were the same, including the blood pressure question, right? We also said the same thing: avoid hypotension and avoid hypertension, because the evidence was not that strong.
Yeah, so in a way, I think this was very reassuring to us that we're kind of reading along and following this process, that these aren't widely divergent guidelines. In fact, they're quite similar. I guess that brings up a question of why do we have 2 sets of guidelines? And moving forward, is there any interest in trying to bring these processes together, or is there benefit from having 2 separate guidelines?
Yes, they say. I mean, I think it's probably important to continue having maybe the 2 voices, and I think simply because the methodology is different, and it's good to see, like, when for example, with these 2 guidelines, that there is agreement, overall agreement, which is great because we're looking at 2 methodologies, and I think it's important because that will give more validation to the points. The criticism for the grade, of course, is that it really limits the number of recommendations that you can give. Now, I'm saying that now, but obviously grade has been evolving. So from what I know, maybe 10 years from now, the methodology may be completely different. Maybe would allow for a broader approach to the specific diseases that we're doing. But one advantage of the American Heart Association is that the methodology has been around also for quite some time, and they apply the same methodology across the board, right? So from all the other conditions, and that's been already tested, and that's also been shown to allow for a broader set of recommendations.
Perhaps this is a silly question, but what is the point of the guidelines? I think some people are uncertain on that. If we go through all the data and we basically say, well, we're just not sure, there's not enough data to recommend for or against all these things that we do or don't do in our ICU. How much guidance is that actually providing to someone who's looking for guidance in perhaps when taking care of a patient that they don't have much experience with?
Yes, that's a very good question. And I think what we need to go back to the issue that guidelines are intended to define practices, right? That practices that are meeting the needs of patients, in most but not all cases, right? So we're not going to have great evidence for everything that we do, but they do offer, they define the practice, right? But we should also have to keep in mind that they do not replace the clinical judgment. So that we still have our clinical judgment, because we need to set everything into context, right? So the context of that individual patient, right? Maybe, yes, sure, maybe we'll have a strong evidence for treatment X, but the patient's values or preferences are different, right? Or the associated conditions that have that patient in the ICU are also different, and maybe the patient may decline that intervention, or maybe the treatment, the providers may decide that they don't want to apply that treatment to that specific patient, even though there is strong evidence for various reasons to individualize the therapy to that patient. But they do help define the practice, but they don't. We have to keep in mind that we still have our judgment, that we need to use.
One question that I've heard come up is, are there malpractice concerns around guidelines? If I'm perhaps using an intervention in which your working group has said, well, there's no data to support the use of XYZ, hemoglobin transfusion up to 10, let's say, and yet I'm transfusing someone and they have a horrible reaction to that transfusion. Am I somehow at risk for that?
It's a good point that you're bringing up here, because we live in a litigious society, right? And yes, and we need to address it. And some of the guidelines sometimes have been used for against us, against us, the practitioners that were working out there. But I think it's also important to look at the guidelines, and you can develop your protocols, right? And then you can have the protocols in your institution that will set what type of standards you want for your patients at your institution. And I think that will be more important, because you can also have agreement among all the practitioners. We're already saying there's a lot of variability, right? So, and that's a strong statement to use, against the litigious society out there. Where, we have a lot of variance, and what you get in at Strong Memorial Hospital is not the same that you're gonna get at the Lady of Mercy Hospital, right? Just to come up with some made up names, but and I think that's important to keep in mind. As long as you have the protocol and everybody has agreed on, then I think that will protect you, also protect us, because we're sort of following what we agreed to do.
Great. And then my last question for you, we hear we're approaching at least the era of, as you said, individualized or personalized medicine. How do we reconcile that with guidelines and wanting to make sure that in general we're providing guideline concordant care?
Yeah, so that's a question that we are a little bit harder to address at the moment, but I think that brings up the issue that we also need to incorporate more machine learning techniques, if you will, that will help us hone into what's good for an individual patient and not for the entire population. And that's what also brings up the same point that you raised before about reaching out to our colleagues around the world to increase the sample of patients that we're utilizing, so that we can apply these machine learning techniques and come up with what we think is reasonable for that individual patient. For example, that will help us decide, we can do clustering of patients, right? And then we can decide, okay, Mr. James came in today, and Mr. James' profile looks similar to all these other 1,000 patients for whom, this therapy worked or was harmful, and therefore we may not apply to Mr. Smith at this point, right? So, and I think that's probably I'm not saying that that's a panacea, but it's certainly part of the future of treatments for SAH. I may apply to all our neurocritical care patients, and so we probably need to consider that applying more of those principles to our patients.
Right. And there's a difference, right, between just sort of going off the cuff and individualizing treatments for the patient in front of you without a research basis to do that, and then instead building a research base to look at things like autoregulatory function using CPP-opt and having sort of personalized blood pressure goals. I think the two a little bit get conflated. This kind of, oh, I'll just treat this patient differently because I feel very strongly that they need a different treatment, versus, oh no, there's a literature basis for individualizing this physiological target, and that's what I'm going to use to guide my treatment.
Correct. Yeah, I think I agree with your statement, and I think that's and we owe it to our patients, and we owe it to ourselves too, so to be more precise, if you will, so that we can develop these algorithms where we can validate them not only prospectively at our own centers, but also across centers, to make sure that what works, let's say here at Hopkins, works also University of Maryland, so make sure that we maybe we have to do a little bit of tweaking at University of Maryland because the patient population may look a little different, and then we have to adjust the algorithm to that population, and that is fine as long as we do it more scientifically. Yeah.
Any last thoughts for the listeners?
No, I think that read the guidelines, look at the areas. I think pay a lot of attention, especially if you're interested in developing this field even more. Look at the areas where we talked about knowledge gaps and about future research. I think that's important to pay attention to because we need everybody's help to move the field forward. So pay attention to those. And if you're interested in doing a study, by all means, go ahead and do it and develop it, execute it, and maybe that will help us change the guidelines of the future.
Yeah, perhaps there's a different way of thinking about these guidelines, but really in some ways they're a blueprint for scientific research needs and a gap assessment. So they really help young investigators figure out where to focus their time.
Correct. I agree 100%.
Great. Well, thank you, Jose, so much for joining us on the podcast. Really appreciate
it. It was a great pleasure.
All right. Well, thank you to our listeners for listening to the Neurocritical Care Society podcast. This podcast is available on the Neurocritical Care Society website, and continuing medical education credits are available for select episodes. Thanks so much for joining us. Take care.